So welcome to our session on wound care. And in vascular surgery, I'm Mark Adelman, and I'm joined by Professor Neville, Professor Hingorani, and Professor Storck. So wounds are something that has been falls within the purview of vascular surgery, as we all know from the VEITHsymposium. It's something that we must deal with because we're the experts, even though we're not the wound center per se, or we may be the wound center, but oftentimes treatment of arterial and venous disease and even diabetic disease will ultimately yield a successful wound healing. So we're here to talk about some of the innovations, and I'll go to Professor Neville first and ask you, Rich, what type of wounds are we dealing with? You got a wound center.
Yeah, no, thanks, Mark. And I'd like to congratulate the symposium on this. This is a great topic. This is a hot topic. Wounds are a major problem. $90 billion in the country are spent on wounds. And we can do elegant revascularizations, but if we don't have good wound care, it's all for naught. So yeah, we have a multidisciplinary wound center. We have 4 wound centers which feed up to a limb preservation center. And the keys are to diagnose the wounds properly, which is not done very often. If you look at the Medicare database, most wounds are just called chronic wounds. They're not diagnosed properly. So the first step is to diagnose properly, treat that in whatever is based on that diagnosis, then treat the wound. And there's several ways to treat the wound. And finally, I think we have to address the socioeconomic factors that are implied by wound care as well. As a comment, I'm on a committee that's with the American Diabetes Association, which is putting together an amputation prevention wound healing alliance. The ADA is finally recognizing the problem with wound care in diabetics, so there's more to come on that.
Great. Anil, Professor Hingorani, so I alluded to it earlier about the different types of wounds that we're dealing with as vascular surgeons, and maybe it's worth going over the spectrum of wounds that we're dealing with, and then we'll go to Professor Storck about some of the innovations about what's happening in wound care.
So a lot of the things that we want to look at in terms of diagnosis are indeed arterial and venous components, but also a large portion of our patients are diabetic foot wounds, and that's a component that is still a huge number of patients that we see. It's an expanding pool also as the obesity epidemic in the US and worldwide is expanding. The number of diabetics is also expanding. And a small percentage of those patients end up with major limb amputations. So that's something that we as vascular surgeons need to be able to not only diagnose, as Dr. Neville was saying, and treat appropriately.
Right.
So we see the entire spectrum. However, having said that, there's also a significant component of patients that cross all 3 of those boundaries. And those can be especially difficult to treat.
But there's, we've got a vascular component oftentimes to wounds where there's maybe low arterial perfusion, oftentimes a venous component where we don't get good venous drainage, you get venous hypertension, and then the diabetic triopathy, with neuropathy and arteriopathy and immunopathy in the diabetics. And so we're faced with different types of wounds, and as you've said, they give us different types of approaches to treating 1, 2, or all 3, and maybe even more etiologies. So you're well versed, Professor, in wound care, and so and I think you have some innovative approaches to it at this point.
This is a great symposium, and I think the importance of wound cannot be stressed enough. 70 to 80% are probably vascular of origin. Some also are of other origin, except diabetes, even dermatologic disease, rare diseases, even malignant diseases. And the key issue is to find out the right diagnosis and then find the right treatment, and also to monitor the treatment over many weeks, up to 3 months. That's the average time, 90 days in a chronic wound, which is defined as 6 weeks not healing wound. And I think the future will be digital. That means not only making photographs, but using even artificial intelligence support for communicating between doctors, nurses, and nurse specialists. In Europe, we have an evolving number of specialized nurses taking care of the chronic wound pathway at the end of the treatment, because we cannot treat all of them in the hospital. And we are developing now a new app, maybe I can present next year here, that will help to make correct diagnosis, to stage the wound. Also, we have the problem of infection. We have the problem of exudate management and choosing the right selection of bondages. And we have a reimbursement problem because it can be getting very expensive if you use the wrong stuff or too much. So this could be a role for IE support to help you to optimize the treatment for these multidisciplinary diseased patients.
Mark, you mentioned innovation, and I would argue that there's more innovation ongoing now in wound care and wound care products and new technologies than the vascular world. There are new things coming out every day. In our wound centers, we have a hard time sifting through what we want to use and what we don't want to use. There's so many different options. So we're really hungry for data regarding these options. There's skin substitutes, there's enzymatic debriders, there's PRP, there's the topical oxygen therapy, which we're going to probably embark upon as well. So it's an exciting field, and I think we can really make an impact doing good clinical trials and some good clinical work.
And as you point out, many of these patients will ultimately end up with an amputation or some major, and the pain associated with these wounds is tremendous. And there are many components to a wound, right? As we just talked about. But I mean, just whether it's arterial, venous, or ischemic, we're talking about whether perfusion is okay. We're talking about infection. We're talking about, and then you talk about your artificial intelligence. It's one of those things where someone says, well, how do you know if a wound's healing? And generally my answer has always been, I don't know, but I know it when I see it. I can't explain it, but I know it when I see it. You look at a wound and you see epithelialization from the edges, you see good granulation tissue, then you start to, you know when the wound's healing and when the wound's not, infection, and you know when the wound's not healing. So I don't know if your app solution is going to be able to measure some of those things.
Well, the problem is not the healing wound, but the non-healing wound. And there might be biofilms and might be non-invisible bacterial films which you need UV light to illustrate the biofilm. And I think this needs sharp debridement more than other wounds. And maybe we need to distinguish the normal healing chronic wound from the others. And this is what the app is actually designed for. Not for the wound where you can see that it heals, then it's fine. But unfortunately, it doesn't happen all the time.
Yeah, I mean, we've had some innovations over the years. Every so often, there's been a new quantum leap forward. I remember when I was maybe just out of training, we used a platelet-derived growth factor on the wounds, and maybe that was good, maybe it wasn't. But we now have some new innovative solutions. Have you seen a change in your practice, Professor Hingorani, in how you go after these wounds?
So for those patients that are having wounds that initially we thought were not going to be healing, we tried arterial revascularization, we tried venous revascularization, we tried everything, compressive dressings. We started using this new therapy with compression with oxygen. And it's a humidified oxygen source, so it has a multimodal component to it. And we were very surprised. Initially, we were very cynical about this because oxygen has a reputation of not working. We used it, and we found in some patients it worked really, really well. This was especially important during COVID when a lot of our patients didn't want to come to the hospital, they didn't want to see me in the office, and they most certainly did not want to go to a hyperbaric chamber. So we started using this, and we had some very good results. This is an adjunctive therapy for what you're already doing. If you're wrapping the patients with Una boots, this goes over the Una boot. If you have a split thickness skin graft, this goes over the split thickness skin graft. If you have a total contact cast, this goes over the contact cast. If you have a bypass, angioplasty, whatever your standard is now, this is an adjunct to help heal the wounds faster, especially those wounds that may have multiple components. I actually think that the compressive component helps with the tissue edema in the wound, and I think that might be an underappreciated cause of these wounds not to heal.
So, Neil, is that how it's different than standard HBO? Because we all have tried standard HBO and diving people in chambers. How is it different than just topical oxygen therapy that way?
Besides the compression that it exerts, which is not that much, it's only 37 milliliters of mercury twice a minute for 90 minutes a day, 5 times a week. So most of the time the patients are off of the therapy and they're going about their normal activity. It's done at home. The oxygen source comes from an oxygen concentrator. It's actually very convenient and it's a lot cheaper. So the fact that I think it's at home, the patients really appreciate it, quite frankly. The fact that it's a lot cheaper, I think the insurance companies appreciate it, and I think a lot of our patients are much more adept at using it once they start using it. And the pain gets better, as you said, and the edema gets better. That's one of the first signs that we see that this is starting to change the course.
Do you have to debride the wound before you do this, or can you put this on an undebrided, so-called dirty wound, or do you want to do a debridement first?
So this particular therapy does not need to have a debrided wound. Unlike some of the constant diffusion oxygen products where you have to have a clean wound without infection. This can have deep sinuses, it can have a plantar ulcer, you can have an interdigital wound, because it encompasses all the way from the toe all the way to above the knee. And some of our patients have wounds all the way up to the knee. So that's a significant problem for some of these other therapies that are much more portable. One of the problems with this particular therapy is because it does have compression, you can't use it with acute DVTs. So all of the patients get screened before they undergo this therapy. With chronic DVTs, you can use it safely.
You seem very enthusiastic about this technique, and it really evolved from necessity during COVID. Part of the problem we have with our wound patients is they're oftentimes non-compliant. And so doing this at home for just a short amount of time each day so who makes is there a company that is using this device and FDA approved and they can do it at home? And I want to ask Professor Storck about the app and how this can be used either in the clinic, or we were talking before this discussion about how it can even be used off-site, and transmit data from the app.
This is an FDA-approved product from American Oxygen Therapy Incorporated, and it not only is FDA approved, but it also has CMS. We're pursuing CMS approval, but right now it's approved mostly for managed Medicaid, and that's right now somewhat limited, but it is expanding, and I think it's actually an important component. But really, what's important is that it's an adjunct to what you're already doing. It's not replacing what you're already doing. It's to help heal the wounds in addition to what your standard of care is.
And Professor Storck, you spoke earlier about this app that you've developed that's going to help monitor wound healing. And so what does the app measure, and how is the data acquired?
Well, first of all, I'm not the only one developing a wound app. There are many around on the market. Our concept is a little bit different. And the problem is that we want to monitor the wound, but we also want to establish measuring the quality of the wound care. Before this will be reimbursed, we need to make a study with 2 groups and showing that there is improved care with using the app and if not using the app, because if the app is approved, it can be given to the patient by prescription, for instance. And so this is the first step we have to do. We have to first prove the quality of care, which is not only the parameter of wound healing, but also quality of life, infection control, and stability of the wound, and palliative wounds, burn wounds. There's a big spectrum for this app, not just vascular wounds. So this will be a big challenge. So I think we start small with venous and arterial ulcerations, and we will see whether we can help so many people that are involved to communicate better and to give them some ideas, for instance, how to cover the wound and when to give yellow or red alert if there is something going wrong, to find out earlier. This is what they have to do.
And we're doing a clinical trial now. We've got about 35 patients enrolled. It's called the Kent imaging device, about the size of a small laptop, which you can take a picture of the wound. It gives you a perfusion status using near-infrared spectroscopy. It monitors the wound very precisely in terms of size, and we're working on tissue typing to see if it's granulation tissue. So there are a lot of these devices coming out. We're very excited about this device. So the nurses love to use it in the hospital, about the size of a laptop. You take a picture, it goes into our medical record. You can monitor patients, but it gives you a perfusion assessment and wound characteristics and size very accurately.
That's great.
I mean, there's a lot of cool stuff coming.
If there was a state of the art, we know this from cancer, like pancreatic cancer. If there was a state of the art that always worked, we would all be using it. But
Yeah.
but it's but it seems that we haven't yet achieved the holy grail.
No.
And we're just all still playing with different options to try to get the best way for the wound to heal. And you can see by the gray hair in all 4 of us that that it takes a little bit of gray hair to be able to assess these wounds properly using both just subjective observation but also objective data, such as perfusion and whatnot. And so so you've got a big wound center at Innova, and and you're using lots of things, I would imagine.
We are. So we've got 5 wound centers feeding to our limb preservation center. We've got 8 hyperbaric chambers at all locations, and we've got a big program. So we are using lots of things. We're going to start, I think, with the topical oxygen therapy. We're excited about that. We just started with PRP. We used, a variety of skin substitutes for our wound care, but it's really the combination. When somebody comes into our limb center, they see a soft tissue person, usually a podiatrist, and a vascular person, usually me for now, and they get an opinion from both. They come up with a plan. We have vascular lab right on site. So you get a vascular lab study, you get the soft tissue opinion, and you get the vascular opinion, and it really cuts down on the number of visits they have to make, and it really streamlines their care. So, the Holy Grail, that may be the Holy Grail, because these wounds are there's such a variety. There's not going to be one thing that cures them all.
Right.
But I think a multidisciplinary approach with expertise like this on board and interest, that's the thing. You just have to be passionate about it. So
Right.
people say, how do you start one of these things? Just be passionate about it.
Right.
If you have an interest in it, the patients will come.
Right. And you're about
Trust
to
me.
start advanced oxygen therapy.
I think we are, yeah.
Yeah,
We just heard about it and looked into the data and have looked at it, so I think we are.
But, Professor Storck, is this available in Europe right now or not yet?
You mean the oxygen therapy?
Yeah.
Yeah, it's recommended in the guideline with the evidence not too high, and that's a question of reimbursement. We have a few centers, we do that, but I think it's not yet routine. But it's an accepted standard therapy for selected patients, and the question is a good selection, and then we refer them to specialists.
I want to thank the panel here. I think it's been an interesting discussion, and I think we've gotten a good overview of what's available and the multidisciplinary approach. I just want to say thank you all. And if you have any questions, if anyone's looking at this video has any questions, we've got Professor Storck from Germany, Professor Hingorani from Brooklyn, New York, NYU, and Professor Neville from Virginia, Innova. I'm Mark Adelman, and it's been a pleasure talking with this esteemed group. Thank you.